Hi, Dr. Roadhouse, and welcome to the Ask Dr. B show. This is the second episode. We're going to be discussing the Forgotten Thyroid Patients. Sorry to run a little bit behind, had a real busy morning, and had some really exciting results today. Obviously, we're on live Facebook. If you have any questions, you can go to this email right here, our Gmail, AskDrBShow@gmail. We've had quite a few questions. We're going to try and cover those at the end. So basically, we're going to be talking about the Forgotten Thyroid Patient. And so I'm going to review a little bit, and then we're going to talk about some more things that can affect. We're going to talk about the 6 patterns of thyroid dysfunction. So basically, let me tell you a little bit about myself while we're waiting for some people to get on. I'm a chiropractor, and I have a regular chiropractic practice. I do sports injuries. I was a team chiropractor for the Tulsa Oilers of the East Coast Hockey League, the team chiropractor for the Tulsa Zone of the Continental Basketball Association. I was a chiropractor at the PGA Championship when it was here at Southern Hills. I was a chiropractor providing chiropractic services for the golfers, and I also did it for the USGA when they had their championship here at Southern Hills also. So anyway, I've been doing chiropractic for a long time. That I had a couple of patients over the years that just kind of stuck with me as to, they were getting better, but I didn't realize that they had problems with like peripheral neuropathy, thyroid problems, fibromyalgia, irritable bowel syndrome. They just weren't seeming to get better, and ultimately that affected their treatment in my office, where the same type of patient didn't have these issues would get a lot better. So I started searching and started doing functional neurology and functional medicine. So on those type of patients, that's what we do. Functional medicine, functional neurology. Sometimes there's some toxicity issues, amalgams, heavy metal poisoning, so different things like that. But for the most part, we focus on the functional medicine and functional neurology. So anyway, my first patient was Cheryl, and I cut my teeth on Cheryl as far as taking care of these type of patients. And when I get done telling you her story, you'll understand why. Cheryl was a nurse. I'm over at St. Francis Hospital. I'm in the Kelly Medical Building, which is on campus at St. Francis, and she was a nurse just right across the street. And ever since she was 9 years old, she noticed that in the neighborhood she would, couldn't play like the other kids. She would ride her bike around once and she'd be huffing and puffing and worn out. The other kids could play all day long. So they took Cheryl to her family doctor, and the family doctor said, well, it looks like she's got a thyroid problem. I put her on thyroid medicine. So years go by. By the time she comes in to see me, she's in her 60s. And so she had all these thyroid symptoms, but nothing ever came back in the labs. And she's over here at St. Francis. Her doctor tried as hard as he could, and they were always talking about things. They tested her twice a year. So anyway, once I started taking these classes, I thought, as soon as I know how to do this and get well at it, and I'm gonna talk to Cheryl about doing this. So anyway, once I got confidence and I took all the lessons, I took them from Dr. Johnson, I took them from Dr. Andy Barlow, who is a chiropractic neurologist, Dr. Johnson's chiropractic neurologist, Dr. David Clark, who is a chiropractic neurologist and also does functional medicine. So I took other courses along with that. So anyway, I felt real comfortable, so we got Cheryl in, did all her intake. When we have a patient comes in that has these type of symptoms, we usually have about 10 to 15 pages of questions that we ask them. It's really in depth because we want to make sure that the patient is a candidate, because if they're not, we're not going to be able to help them. So anyway, Cheryl comes in and we do the paperwork, we do the neurological exam, and we find out that, okay, her cerebellum's not working right, and if the brain isn't functioning right, it can't send signals down to the organs and then get sensory signals back up to let it know it's working right. So you can get dysfunction there. And then we did all the lab work stuff. So anyway, we did the test. She was a candidate neurologically. Then we had to go through all the paperwork. We found out that she was a candidate from the functional medicine standpoint. So we did all the lab work, and she'd always had her TSH tested. sometimes even T3 and T4 now is it. So anyway, this is several years ago. And so we did the thyroid test. I'm going to go over the labs we do in a little bit, but we do 11 tests, 12 if we think we have Graves' disease, because there's certain antibodies for Graves' disease. So anyway, we get the labs back, and she had all these other issues, but the big thing that we found was that she was autoimmune. So a lot of the patients, when you've been to doctors or you've tried to do things on your own, and your labs come up normal, or maybe they're abnormal and they give you medicine, but whatever the deal is, you're not getting better. Those are the forgotten patients, because after that there's not a whole lot that they can do for you. So anyway, we got her on a program, and the neat thing about it was that before she came into me, she gained so much weight that she actually did the gastric bypass. So gastric bypass, she was real happy because she lost 56 pounds, which most of the time she said that near the end when she tried to lose weight, do exercise and a stricter diet, she ended up gaining weight. So when she did that, she lost 56 pounds. So once you have gastric bypass, you only have a stomach about that big. You can only eat that much. And all of a sudden, she's gained 22 pounds back over a couple of months. That's when, we talked about it, and she decided to come in and do the program. Anyway, we had all kinds of cool things that happened. Or one of the neatest things was that she always had problems controlling her blood sugar, and always had problems controlling her blood pressure. And so anyway, she was doing really well, and then one day she comes in and she's feeling faint. She's so I thought maybe she had the flu or something like that. And I said, but you might want to go and talk to your doctor about this and see if there's anything going on. Went back there, they checked her blood pressure. Her blood pressure was down like 70/40. And so he didn't understand, so she told me she was doing the program. He was excited about it because he had tried for 40 years and really couldn't do anything for her. So anyway, what happened was that she was on 5 blood pressure medicines, and when we worked on her, got her thing working right, getting the liver working right, it brought her blood pressure back down and normalized out her blood sugar also. So anyway, I just want to let you know that was probably one of my toughest cases that I had. And definitely for my first one, it really got me ready to take care of a lot of patients. So anyway, I kind of want to go back and review a little bit about the thyroid. Basically, your brain, the hypothalamus, has to send a signal down to the pituitary gland. The pituitary gland then sends another signal down and sends thyroid stimulating hormone to the thyroid. The thyroid then produces 3 hormones, T3, T4, and luteinizing hormones. So if they only check TSH or T3 and T4, then they're not really checking out. In a little bit I'll go over the labs that we do on the thyroid. But also luteinizing hormone. This is really important for women that have a thyroid problem, because that's when you're going to start seeing low libido. They might be growing hair on their chin or in other places that normally don't grow hair. Their energy level can be off. They can have all these things that are affected just by the luteinizing hormone. And a lot of times when you fix the thyroid, you're going to fix a lot of the female hormone problems. So anyway, so that's the main thing. Then what happens is T3 is in 7%, T4 is in 93%. T4 is the unusable or inactive thyroid. It has to be converted from T4 to T3. And it does that in several different areas. Number 1 is in the liver. 60% of that T4 is converted T3 in the liver. So if you have any liver dysfunction, if you're taking any medicines that you have to get tested, like Humira and stuff like that, they say, well, hey, we got to do a liver test on you every so often, that can cause liver dysfunction. The other thing that can be, and this was a big deal a little while ago, but Ally, that medicine that was like a fat blocker, that affected the thyroid. If you're taking any medicine to help with the cholesterol, then that affects the liver function also. So if that's not working right, then your T4 is not going to be converted into the usable T3. The next place it goes, or another place it goes, is the gut. So if you have intestinal permeability issues, if you have irritable bowel syndrome, if you eat food and your stomach bloats out, chances are that's not working right. And if that's not working right, it's not going to get converted from T4 to T3. The next area is the brain, where 20% of it, the brain, the kidneys, and the muscles. So when you ache and hurt all over, a lot of that has to do with it. But also the brain. When we are talking about the cerebellum, the neurological part of it, that's what we're talking about. So if the brain is not functioning right, if it's inflamed and the brain is somewhat swollen, then it doesn't function properly, and because of that, it's not going to get converted. So those are the main things. And then when all those, if you have all those things going on, and then you need to look at autoimmune, because autoimmune trumps all that stuff. So you can have autoimmune, and you can have any of the 6 patterns of thyroid dysfunction too. But there's other medicines. There's 28 identifiable factors that affect thyroid function. Like you can have H. pylori bacteria, which is a bacteria in the stomach, and that can cause the thyroid to not function properly and actually be hypothyroid, even though all your labs would be normal. And there's other medicines like Zoloft, Wellbutrin. I mean, we have a list of them that can actually cause the thyroid not to work properly also. So there's a lot of factors. So my point in saying all this is that last week when we were talking about it, I was trying to explain to everyone that's out there watching. I appreciate Patricia Chapin, David Siegel, and Katie Tiergarten for watching and giving us some love out there. But there's other things that can affect it, so you have to look at everything. So the forgotten patient is either they have all these symptoms and they do your labs and they're normal, or they do the labs and your TSH is off, so they give you thyroid medicine and you don't get better. So obviously that means that you're one of these other patterns of thyroid dysfunction, or you're autoimmune and you have these other issues. So when we ask the patients and ask the questions on where they're having the problems at, those questions lead us to, oh, okay, they're having a problem with their adrenals, their cortisol levels off, they're having trouble with the liver, you know, they have irritable bowel syndrome, you know, so then the gut function, like they might have H. pylori, they might have hydrochloric acid might be out of kilter in the stomach, so they're not digesting food, and that's why a lot of patients get reflux. It's not digesting it, pushes it into the small intestine is pushing it back up. They go, hey, we're not ready for this. That's why you get reflux. So there's all these things that can affect it. So the happy patient, like we talked, H is up about 4.5 or 5.0, whatever labs you're using. They take the medicine, and then all their symptoms go away. So that's those type of patients we don't see because they're doing good. It's the patients that have tried all these different things. We might have this.
Go.
So we had a little pause there. Last time we didn't have a pause at all. This time we did. So anyway, as soon as I saw that my staff put the hand up, that meant it was pause. So I didn't say anything. You haven't missed anything. So anyway, there's all these different factors that can affect. These are not easy cases. I have a lot of patients that have tried, you know, going vegetarian, drinking nothing but water. They still have problems because you still have to fix what's going on. So anyway, today what we're going to do is we're going to talk about the 6 patterns of thyroid dysfunction. And you got to remember that there's also autoimmune. So you can have an autoimmune situation, which is really not a problem with the thyroid. It's the problem with the immune system is mistakenly attacking the thyroid. And there's a bunch of factors, and we do the labs so that we know exactly what your triggers are. But the first pattern of thyroid dysfunction is primary hypothyroidism. Primary hypothyroidism, you're going to go to your doctor, they're going to do the labs, you're going to go in, you're going to tell them all the symptoms, him or her, all the symptoms that you have. They go, yep, looks like you got, you know, a thyroid problem, let's do the labs. You do the labs, they come back 4.5, 5.0, whatever lab you're using, and it's above like that. They prescribe medicine. You come back in 3 months and they go, how you doing? Whoa, I'm already feeling better. That's the one that we don't deal with. Now, sometimes those patients can still have other things, so they get some improvement, but then they stagnate. If you stagnate and your improvement. They don't all go away. I've had patients take it for 20 years and and they're still on the same levels. They might have tried different medicines, tried adjusting it, and they had some help, but they still have symptoms, and you might have some other things going on. The second one is secondary hypothyroid, which is really hypofunction of the pituitary gland, and that is secondary to thyroid. So what happens is the signal from the pituitary thyroid is not getting there right. And if you have labs, you can go look at your labs, and if your TSH is low, your total T4, if it's below 6, then you could have a problem with that. But then again, you have stress, you have cortisol, you have blood sugar imbalances, you have leaky gut, you have low-grade bacterial, virus, fungus, yeast. All those low-grade infections have to be taken care of. So there's a lot of things that go along, with this one. So basically, that one, the pituitary, the hypothalamus, that's when we put the patients on oxygen and we do the neurological treatments to make. So anyway, we had a little pause there. I'm going to get right back to where we were. So anyway, we're talking about, could be a low-grade bacteria, virus, fungus, yeast, or, any kind of a low-grade infection that can affect the performance and the overall functioning of the thyroid and the brain. The next one, pattern of thyroid dysfunction, we're going to try and get through these pretty quickly because all of a sudden time's flying by, but thyroid underconversion, so that means that, you have 97% T4 and has to be converted to the T3. Means something is happening where it's under converting. So usually that means it's a problem either with the thyroid binding globulin that is taking it to the sites where they need to be converted, or there's an actual problem with the conversion site. And we already kind of talked about that a little bit ago with the function of the liver, the function of the intestine, and the brain. So anyway, if you have labs of that, obviously, you could have a decrease of reverse T3, or it could be normal. You could have decrease of T3 and maybe a decrease of total T3. But you're going to have less T3 because it's under converted, not being converted all the way. And there's no medicine that's going to work on that. Now you can have thyroid. The next one is thyroid overconversion, and that's where you have too much T3. You're going to have on your labs, you're going to have increase in T3. You're going to have an increase in free T4. But the main culprit on this one is increase in testosterone for women, and that's when you're going to see like polycystic ovarian syndrome. You're going to see thinning on the hair up here, but they're going to get hair on their chin or in other areas that they're not used to having hair. And I was just at a conference just recently, and another way that a patient can get this overconversion is if their partner has a testosterone problem. That they do injections, they do pills, but they also do creams. And usually what happens is they'll have you rub the cream on, it's transdermal, it goes through their skin and gets in. It can also go to your hand. But also, you can be absorbing it from just laying in the bed with them, being intimate, rubbing the cream on. So if we find out that you have this, you might, and that is the situation, we might want to have you talk to a doctor. Maybe they can get a different form of testosterone because it might be helping his health, but could be ruining your health. And then the next one is going to be elevated TPG. That's a thyroid binding globulin. And usually a factor in that is excess female hormones, where the last one we're talking about was increase in testosterone. This one is like estrogen dominant. You could be taking hormone replacement. You could be on oral contraceptives. If you're taking Premarin or anything like that, you're getting huge amounts of estrogen, and that makes it where it doesn't function properly. So on that one there, on your labs, you're going to have increased TPG, decreased free T3, increased T4, free T4. The last one is thyroid resistance, and that's just because, when you get looked at it, the labs, all your labs are probably going to be normal. You got good conversion from T4 to T3. Your TSH is good, your normal TPG. But what happens is that stress causes the problems, and so cortisol makes it where things don't work right, the blood sugar doesn't work right, and that basically, another thing you can have a problem with that is you can have vitamin A deficiency. You're going to see homocysteine, C-reactive protein, which lets us know that all your labs are normal, but those are markers for inflammation. What do we say blocks it? Increased steroid, cortisol, whether it's normal or you're taking inhalers, if you're taking Flonase, if you're under stress a lot and your cortisol levels stay up. But anyway, we'll get more into that next time because we're running out of time here. And I just want to go over a question. This is from Poka Hinlu, and she said, I had a biopsy, but it was not cancerous. Do I need to get another one? And then she left a comment before that said, I have nodules and a big goiter. They say my levels are always normal. I just don't know what to do. I don't want them to take my thyroid. If nothing is wrong, please help. So the number one reason that patients have nodules is because the thyroid is not working right. Now, goiter can be something as simple as an iodine deficiency, but it can also be one of the problems when you have these other patterns of thyroid dysfunction. Sometimes when the goiter gets so big, you do have to have it surgically removed, but sometimes it can come back. So we need to find a doctor for you that can evaluate you and see if you have a problem. You can call us here at this number, 918-481-2770. If you're in the area, we can schedule an appointment. If you're somewhere else, I can find a doctor for you in another area. But so to the other question, she had a biopsy, it's not cancerous, do I need to have another one? Most of the time, you're going to have nodules with that, and they do need to check to make sure there's not cancer going on. In this case, there's no cancer going on. I don't know how long ago you had that done, but really that's going to be up to your doctor to look, because I don't really know a whole lot about that. But if you just had it done recently, you don't need to do it again. But they might want to check it again in a year or so, especially if it grows. So, but it is one of the most common symptoms that patients have when it comes to a thyroid. You're going to get nodules, you're going to get goiter. And like I said, sometimes the goiter can just be an iodine deficiency, so you can go and try some iodine first and supplement and see what happens there. So anyway, we're about running out of time. I didn't get to all the questions. If you want a question answer on the next one, AskDrBShow@gmail.com. And I'll see you next Tuesday at noon. If you have any questions in the meantime, email us and we'll try to cover them at the next thing. And I want to thank Sean Stevenson for liking our page. I want to thank all the patients that have shared the pages and that tuned in. And hopefully you learned something from this show, and I'll see you next Tuesday.